Hello, my name is Kate Chesterman. Welcome to the GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. You can find us on all major podcast platforms, including Spotify and Apple and Google podcasts. Please follow us to receive notifications about new episodes, and if you like what you hear, please consider leaving a review to help other listeners find us. You can also visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. Today I'm going to be discussing Parvovirus B19 infection, also known as fifth disease or slapped cheek. Let's start with a case study. Evelyn has been brought by her father, who is concerned that she has a temperature and has now developed a rash. Evelyn is a healthy 6-year-old child. She has no long-term conditions. Her father tells you that last week she had been off colour for a few days with a mild temperature, runny nose, headache and sore throat. She seemed to be getting better, but today has developed a rash and they're concerned about the cause. You note that she has an erythematous macular rash on both cheeks. She's otherwise well with normal observations and no other findings of concern. It turns out that several of Evelyn's classmates have had similar symptoms. Based on the history and clinical findings, you make a diagnosis of Parvovirus B19 infection, commonly known as slapped cheek. Parvovirus B19 is a common virus that primarily infects children. It's usually transmitted by droplets or direct contact with someone who is infectious. It's commonest among younger school-aged children, with a peak incidence in the 6 to 10-year-old age group. Seasonal outbreaks occur every 3 to 4 years in the UK and are most common in spring. The virus affects the erythrocyte progenitor cells and red blood cell production, and this can result in transient anemia or an aplastic crisis in susceptible individuals. For most healthy children and adults, however, Parvovirus B19 causes a mild illness and complications are rare. Children will usually present with a prodromal illness that might include a raised temperature, viral upper respiratory tract symptoms, headache, mild nausea, and possibly diarrhea or abdominal pain. These symptoms will commonly start approximately a week after exposure and 1 to 2 weeks prior to the onset of a rash. The rash develops due to a delayed immune reaction. It is often present on the face in children, where a macular erythematous rash that classically look like slapped cheeks occurs on one or both cheeks. A maculopapular rash can then develop 1 to 4 days after the initial facial rash. This may spread to involve the torso and extremities, and can evolve into lacy reticular patterns. This can last for 1 to 3 weeks, but it may persist for longer, and this more generalised rash may intensify with any increase in body temperature, exercise, anxiety or stress. It's important that parents and caregivers understand that this is to be expected and does not reflect a worsening of the illness. In some cases, a symmetrical polyarthropathy affecting the small joints of the hands and occasionally the knees, ankles and wrists can develop, but this is rare in children. In adults, the diagnosis can be more problematic, as the symptoms are more likely to be atypical. A history of contact with someone known to have the condition, along with prodromal symptoms, and possibly a maculopapular rash on the trunk, back and limbs, should point to the diagnosis, and investigations are rarely required. The typical facial rash seen in children is less common in adults, but adults are more likely to experience the symmetrical polyarthropathy, especially if they're female. This arthropathy can last for several weeks, but rarely persists for months. A more prolonged arthropathy may require a referral to rheumatology for confirmation of the diagnosis and exclusion of other differentials. I think it's helpful to be aware that up to 30% of people with Parvovirus B19 are asymptomatic, and less than 50% actually develop a rash. Most cases in healthy people do not require any management beyond symptomatic treatment and reassurance. The disease is usually self-limiting, and symptoms should resolve within a few weeks. Patients are infectious for approximately 10 days before the rash develops, until 1 day after the rash appears. And so there is no need for children to be off school once they have developed the rash. However, parents should be encouraged to inform the school of the diagnosis so that any at-risk individuals can be managed appropriately. Infection with Parvovirus B19 is followed by lifelong immunity, and reinfection is rare. Reassuringly, human Parvovirus B19 is not the same parvovirus that can infect animals, especially dogs. Parvovirus B19 cannot be passed from humans to animals or vice versa. So thinking back to our case study, Evelyn and her father are reassured that her rash should resolve over the next couple of weeks and that we would expect her to make a full recovery. They are about to leave when her father says that Evelyn's mum is 18 weeks pregnant, and he thought he should just check whether they should be keeping her away from Evelyn. He advised them to sit back down again. Now, it is unusual to have Parvovirus B19 for the first time during pregnancy, but it does affect 1 in every 512 pregnancies per year. Vertical transmission of the infection can occur in approximately 30% of cases, and is most common and associated with the greatest risk if the infection occurs between 9 and 20 weeks gestation. If fetal consequences do occur, they are most likely 3 to 5 weeks after maternal infection. In the fetus, the red blood cell survival time is shorter than in adults, and so infection with a virus that can affect the red blood cells may lead to hemolysis and hydrops fetalis. Hydrops fetalis, which is associated with profound anemia, hypoalbuminemia, and heart failure, can happen in 3 to 11% of cases where infection occurred between 9 and 20 weeks gestation, and it has a fetal mortality rate of 40 to 50% if left untreated. And the overall fetal loss rate following vertical transmission of Parvovirus B19 is about 5 to 10%. Maternal infection after 20 weeks is only associated with hydrops or fetal loss in less than 1% of cases. And reassuringly, babies who are born at full term are usually healthy, with no evidence of problems secondary to infection. So, what should we be advising Evelyn's parents? Well, given that Evelyn has probably been infectious for the past 10 days, isolating her mother at this stage is unlikely to be of any benefit, as she will already have had significant contact, especially when we understand that a significant contact is defined as being in the same room for 15 minutes or direct face-to-face contact within the last 3 weeks. However, there is other action that does need to be taken. In patients who are presenting with a significant exposure or with symptoms suggestive of Parvovirus B19 in pregnancy, we're encouraged to contact our local virology, microbiology, or infectious diseases department immediately for advice about testing and monitoring. A pregnant woman's immunity needs to be determined as soon as possible. Booking bloods can often be tested for past exposure, and testing a new sample for Parvovirus B19 specific IgM and IgG will help to determine the presence or absence of an acute infection, as well as the patient's past exposure and therefore immunity. Parvovirus B19 IgM may be detected within 2 to 3 days of an acute infection and persists in the circulation for up to 4 weeks. Parvovirus B19 IgG usually appears a few days after the IgM and usually remains present for life. So if a patient is IgG positive and IgM negative, this would indicate a previous exposure to parvovirus and therefore immunity. The patient can be reassured and retesting is not necessary. If the patient is IgG negative and IgM negative, then there is no current evidence of acute infection, but she is also not immune and is therefore susceptible to Parvovirus B19. Further testing is recommended 1 month after the last contact even if she remains asymptomatic, and if she develops symptoms, retesting should be performed sooner. She should be advised to avoid other pregnant women and others who might be at risk of complications while waiting for the repeat test. If the repeat sample remains negative, the woman should be reassured that there is no evidence of recent infection. She should be counselled, however, that she is susceptible to parvovirus and recommended to avoid places where parvovirus is common, such as schools and nurseries, while she is pregnant. If a sample is positive for IgM, this suggests a recent infection. It is usually recommended that the test is repeated to confirm the results, but the patient should also be immediately referred to the obstetric team for consultant-led care. Monitoring may include serial ultrasound scans and Doppler assessments of the middle cerebral artery, as this is an accurate predictor of fetal anemia. Therapeutic options such as intrauterine blood transfusions or IV immunoglobulins are available to the obstetric team if needed. Women should also be made aware to report any changes in the pattern of their baby's movements immediately, and also advised to avoid any contact with others who could be at high risk of complications until she is no longer contagious. Any pregnant woman with symptoms of parvovirus should also have their rubella immunity checked, as it can be difficult to distinguish rubella infection from parvovirus, and rubella can also have serious consequences for the developing fetus. It's also good practice to check rubella status in any adult who develops symptoms of parvovirus if they have not been fully immunized to rubella due to the difficulty in distinguishing between the two conditions. So again, thinking back to our case study, you contact Evelyn's mother and explain the need for a blood test. You get this booked in for the same day. You make a plan with her to review the results and advise her to let you know if she develops symptoms. You also advise her to let her midwife know that she has had this exposure. Just before you hang up the phone, she mentions that her father, Evelyn's grandfather, is having chemotherapy for bowel cancer. They had planned to visit him this weekend, but she's wondering if they ought to stay away. In this circumstance, we would certainly advise avoiding contact with their grandfather. Although Evelyn is probably not contagious now, her parents might be, and parvovirus can have serious consequences if contracted by those who are immunocompromised or those who have an underlying haematological disorder because of the effect that the virus can have on red blood cell production. People with a high red blood cell turnover, for example those with hereditary spherocytosis, sickle cell disease or thalassemia, are at risk of developing an aplastic crisis if they contract Parvovirus B19. This can result in a significant decrease in hemoglobin levels. The aplastic crisis is usually transient and self-limiting, but it can result in severe anemia requiring transfusion. Immunocompromised patients don't form immune complexes, and so might not present with the classic rash associated with Parvovirus B19 infection, and antibodies to the virus are usually absent. High viral levels may be noted on PCR analysis, and this investigation may be required to diagnose the condition. Immunocompromised patients are at risk of developing a persistent infection as they are unable to eradicate the virus. This can cause chronic red cell aplasia, resulting in severe anemia. Transfusions may be required, along with IV immunoglobulin, stopping immunosuppressive therapy, or starting HIV antiretroviral treatment, depending on the underlying cause of the immunodeficiency. Involvement of appropriate secondary care teams, including haematology, will be required to manage these patients, and regular full blood count and reticulocyte monitoring will be required for those with acute or chronic infections, as well as those presenting with symptoms of anemia. Finally, those who have symptoms of severe anemia may need urgent admission for investigation and management. So thank you all for listening. I hope you found this podcast helpful. Please do have a look at the show notes that accompany this episode at GPnotebook.com. Feel free to email support@gpnotebook.com if you have any questions, comments, or ideas for future podcast episodes. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and download free shortcuts, which are designed to help make your lives a little easier and ultimately help improve the lives of our patients in primary care.